Ma'am, please start. Sonali ma'am,
Okay,
please
sure.
unmute yourself. Please
Yes.
unmute.
Am I audible? Yeah. So, a very, very good morning, ladies and gentlemen, all our esteemed colleagues and our distinguished guests and speakers. Welcome, Dr. Ram Gopal sir. Uh, Dr. Sonali Pardi, I'm truly honored to get this opportunity to welcome you all to today's session of PATH, which is Pediatricians Actions for Teenagers' Health. As we all know, PATH is a beautiful online discussion program which has been organized by Maharashtra IAP along with the collaboration of Nashik IAP and Nashik AHA. And I welcome each and every one of you for today's session, which is going to be really, really interesting one. Now, this program, which was initiated under the energetic leadership of our Dr. Ramakant Patil sir during his Maharashtra IAP presidency tenure of 2023, along with our enthusiastic working of Dr. Amol Pawar sir, who has been working as a General Secretary of Maharashtra IAP for the last 2 consecutive years. And this program has been a huge success, not just in terms of topics, but also about the information and the participation of our speakers as well as the delegates. So let us continue the path further, off path. Since its inception in the first quarter of 2023, PATH has been successfully running on the first Sunday of every month under the coordination and mentorship of our own esteemed Dr. Atul Kanikar sir. I think sir is about to join us. Then we would have a few words from sir as well. But as we know, our main chief guest of honor today, I welcome Dr. Ram Gopal Chajara sir, President of Maharashtra IAP. And so please, can I request you for a few words
Yeah,
today?
thank you, Dr. Sonali. Good morning, everyone, and a warm welcome.
Good morning.
Welcome to the one episode of PATH, a pediatrician's action for teenager and healthcare, a joint initiative of MA IAP, Nashik IAP, and Nashik AHA. Great initiative by Dr. Atul Kenikar sir, the mentor of this program, and a congratulations to Nashik IAP and Nashik AHA for contributing to the program. Even I welcome to Dr. Sangeeta Loda, the chairperson of AHA Nashik, and Dr. Sulbha Pawar, secretary AHA Nashik. Welcome and congratulations to today's experts, Dr. Trupti Matme, Dr. Prachi Villari, and Dr. Nima. Uh, I think she's Sitapur. And today's moderator, Dr. Sonali. Welcome all. And I think we are already late. So, Dr. Sonali, you can start the program.
Yes, sir. So Atul sir also has joined, I can see. So we'll start off with the discussions today. Atul sir?
Madam, I just want to say that Dr. Chajera has been very kind to allow this program to be, rolled up in this particular academic
Thank you,
year.
sir. It's our honor.
RNA, sir. But I think this is the 15th or 16th program of MAHA-AP, which has been started last year, and we are very fortunate that you have allowed us to continue with this program, because every first Sunday of a month we are conducting this program, and we are cooking up with some new topics of concern for the teenagers and the parents and the teachers. And every time we come up with some, I don't know whether they are good, innovative, or new ideas, but they are, I think, helpful to the teenagers, because
Sir, already there is a century of the participants, so that speaks the success of the program.
yeah. So let us see that even if 1% of the population gets some good insights, that is our success. I count on that. And today we have actually taken up some uh, commonest mental health disorder, that is anxiety. Whether it is parents, whether it is children, whether it is grandparents. Grandparents have a lot of anxiety, and we are going to tackle them with the experts like Tripti Mahatme and Nima Sitapara, who is there, and of course Prachi Birari, who is going to tell us, who is going to teach us about the psychopharmacology of anxiety disorders. So over to you, Sonali Pardi madam. Please
Yes, sir.
continue.
Yes, sir. So let's start off with our scientific session for today. We are honored to have our three speakers with us and who are going to help us navigate through this sensitive topics related to mental health in the teenagers. Our first speaker for today, may I just welcome Dr. Tripti Mahatme ma'am. So a short introduction of ma'am. So I'm happy because I'm moderating the session where I personally know two of the speakers and I've seen them work. So that is a big thing for me today. Dr. Tripti ma'am, she has done her DCH DNB. She's a certified lactational consultant as well as an EQ trainer. She has worked as an assistant professor in pediatrics at the Vasantrao Pawar Medical College from 2013 to 2020 and has been working as a consultant pediatrician in the private sector for the last 10 years in Nashik. So she is enthusiastic participant in most of the IAP and the AHA programs, and her work has been commendable in those fields. So today we are looking forward to hearing your talk, ma'am. Please, can you just over to you, ma'am?
Yes, thank you. Thank you so much, Dr. Sonali. So at the outset, I would like to thank Dr. Atul Kanikar sir and team Maha IIP, Dr. Ram Gopal Chizara sir and Dr. Amol Pawar sir for giving me opportunity to present the topic on this platform. So let us begin with the presentation. Is it visible, Dr. Sonali?
Absolutely.
Yeah.
It's okay.
So before I begin with the topic, let us have a small activity. Okay. Now I request everyone to please close your eyes. Go back to your teenagers and childhood days and try to recall the different anxiety and fear triggers during those days. Let us have few seconds for this. Okay, open your eyes and I invite volunteers to post their triggers if they are willing in the chat box. So stress and anxiety are normal and important triggers in our life. Stress is basically a coping mechanism to the different demands which are put on our body. When the demands are within the coping ability, we function optimally to give the desired result. And when the demands are beyond the coping abilities, then we may give n number of psychological reactions starting from fear, anxiety, etc. So stress is usually short-term to a recognized threat. If it is acute, very severe, chronic stress, which is inadequately managed or managed with maladaptive coping mechanisms, then it may result into anxiety, which lingers, which may or may not have any identifiable triggers. Now, anxiety is also a healthy emotion because it signals our brain that something threatening is going to occur from which we should safeguard ourselves. Albert Ellis, who is a father of REBT, in his book Control Your Anxiety, has mentioned about healthy anxiety and unhealthy anxiety. So healthy anxieties are basically based on rational fears. Like we say, we become cautious or vigilant about the particular situation and we function optimally, or we are motivated towards particular action to get the desired result. So the person is usually within his or her control. Unhealthy anxieties, they are based on irrational fears and they are beyond the coping abilities of the person. So person may lose the control over the situation. So this is how cycle of anxiety develops, how stress shapes anxiety. Now everyone is aware about thought, feeling and action cycle. Thought affects our feelings, moods and behaviors. So if there is any acute, severe or chronic stress, it gives rise to gloomy thoughts. That means altered thinking pattern with extreme and unhelpful thoughts. Altered thinking will give altered feelings, like being apprehensive, fear, anxiety, etc. All these feelings will cause neuropeptide rush and physical changes in our body. These physical changes will push our body towards particular action. So altered thoughts, altered feeling, altered and unhelpful behavior will give rise to impaired functioning. This impaired functioning will again worsen the anxiety and cycle usually continues. Okay, now coming to various anxiety and fear factors in children and teenagers. These are the various common triggers about anxieties and fears, like separation anxiety, stranger anxiety in infants and toddlers, animal phobias or school anxieties during childhood, peer pressures are common during childhood and teenagers. What matters most is disturbed family environment, parental conflicts, small fights between mother and father may affect any age group. Even a 1 or 2 year old child can sense that there is something abnormal which is occurring in my environment. When we talk about teenagers, body image issues, peer pressures, relationship issues like having boyfriend, girlfriend, exam anxieties, career anxieties, all these anxieties are common triggers in teenagers. Now, being anxious time to time a bit is normal in teenagers because it motivates them to take particular action in school, in academics, in sports, in work, etc. So when should we worry about the anxiety disorders? When and why it is important to address anxieties in children and teenagers? When the symptom persists beyond particular time or worsen over time, or they negatively impact functioning in one or more domains such as educational, social, interpersonal domain, personal comfort. So basically, anxiety is internalizing disorder. When it disturbs the internal milieu, it results in disorder. And we should manage those anxieties because childhood and adolescent is a core risk phase for development of anxiety disorders. And if we leave them untreated, then they may result in serious consequences like depression, suicidal thoughts, and even chronic physical ailments that like early onset heart diseases, early onset lifestyle diseases, etc. So what is the worldwide burden of anxiety disorders? It affects nearly 1 in 12 children and 1 in 4 adolescents. This is the recent 2022 data. When it comes to India, this is a meta-analysis study published by Pal et al. In 2022, which includes 13 studies done in India. And it shows pool prevalence of anxiety disorders is 41% and 29% in two different subgroups. So, of course, the burden is quite significant. This is a CDC data of children's mental health where I want to highlight is again towards anxiety, which peaks during adolescent age group, that is 12 to 17 years. And why adolescent brain is so vulnerable to anxiety disorders? Why it peaks during adolescent age group only? This is because the peculiar developmental trajectory of the adolescent brain. So emotional components of brain like amygdala, hypothalamus, hippocampus, they develop early during teenage. And the thinking brain, the cognitive brain, the prefrontal cortex, it develops late by 24 years or even beyond. So there is less of emotional dysregulation, less stress regulation, and heightened fear conditioning, and less of cognitive control. So all these factors, they act together and make the adolescent brain vulnerable to anxieties. And what are the different etiological factors, or what is roadmap to the anxiety? Of course, various factors act together like social, emotional, financial, academic factors. What matters most, I already discussed about, is family environment, parental conflicts. Impact of social media, I think it's a different topic to talk about. The other side of the coin may be acting like a new era monster, creating new era cyber anxieties in so-called alpha, beta, theta, gamma generations. S, that is adverse childhood events. These are basically nothing but the all abuse, traumas, neglects which occur in people less than 18 years of age group. This is being studied increasingly nowadays, and some of the studies have shown that there are permanent changes in brain structure and development due to chronic stressors in age. Biological factors like heritability, temperament, of course, play a major role. High expectations and pressure to succeed from parents. Yes, this is again important factor. Rather, one of the studies done in India in 2001 has shown that this is the most common factor for development of anxiety disorders in teenagers in India. Parental anxiety disorders may predispose children to develop anxiety disorders. COVID-19 was era of anxiety for everyone, including children. So because of continuous bombardment of the media from neighborhood or the discussions in the home, children, they had continuous anxieties. What if I develop COVID? What if my parents will develop COVID, etc. And these are the common stressors of anxieties in teenage. So overscheduling, sibling rivalry, bullying plays very important role. It may predispose even to depression, leadership, career issues, competitions, sexuality and relationship issues. So having a girlfriend or boyfriend is a common anxiety factor. any sort of abuse, physical, emotional, mental, sexual abuse, death of a family member or friend. So all these are stressors of anxieties in teenage. Now, many of these stressors are common to many teenagers. But what matters is the perception towards these stressors. And family and school connectedness are critical factors to develop this perception. If the perception is appropriate, the child or teenager is protected from anxiety. But if perception is distorted, then there are high chances that anxieties will be developed in teenagers. So now let us decode anxieties. As per DSM-5, the anxiety disorders are classified as generalized anxiety disorders, panic disorder, separation anxiety disorder, social anxiety disorder, and specific phobias. Now, pure anxiety disorders are rare to occur in children and teenagers. There is considerable overlap with other mental health disorders or physical ailments. So there is overlap between anxiety and depression. There is overlap with other comorbid conditions like ADHD, autistic spectrum disorder, mood disorder, intellectual disabilities, etc. Heightened anxiety, chronic anxiety will lead to increased adrenaline. An increase in adrenaline for prolonged period will predispose to early onset heart diseases and other lifestyle diseases. Chronic diseases developing early in age group, of course, will again increase the anxiety and the vicious cycle sets in. So as per DSM-5, these are the generalized anxiety criteria. So as per agenda of today's session, I will be discussing more about generalized anxiety disorders and specific phobias. So as per DSM-5, we said that the teenager or child has a GAD when there are excessive anxieties or worries which are difficult to control and they are associated with one or more of the following. That is restlessness, easy fatigability, difficulty concentration, irritability, muscle tension, and sleep disturbances. Duration occurring more days than not in past 6 months and causing clinically significant impairment. So let us have a look at this case. She is Shriya, 16-year-old girl, always appears worried and frequently bites her neck. And what is she worried about? She is worried about her family. What if something bad would happen to them when I am at school? She is worried about her health and what will others will think of me if I get ill. There is history of death of her father due to chronic illness few months ago. There is history of poor concentration and academic deterioration since last few months. There is significant history of school refusal also. Shriya tells that sometimes when she gets anxious, she feels that her heart is pounding, her body is trembling, she becomes short of breath and start to feel sweaty. So this is a HEADS assessment, which is a initial screening assessment for any teenager coming to our OPD. So home environment, there is history of death of father. She has a 13-year-old brother with whom she constantly indulge in lots of fight between them. There is no other elder at home apart from their mother. Education, Shriya has moved with family to the other city and school after death of father. There are no any close friends in the school. History of academic deterioration and school refusal is there. Activities, most of the time she is engaged in mobile and laptop in her spare time, not involved in any group activities or any physical activities. Sexuality, in her old school, she had a boyfriend who is now avoiding contact with her since she has shifted to a new place. Now, before going to approach to this case further, let us understand what are the clinical features of generalized anxiety disorders. So as I have already said, there is excessive anxiety and fear which is out of proportion to the situation. And these teenagers, they present with physical symptoms of autonomic nervous system activation like diaphoresis, palpitation, chest tightness, nausea, fainting, etc. The behavioral response is typically exhibited by avoidance of or reluctance to engage in a particular activity. So avoidance is a core feature of any anxiety disorder. Body typically exhibits flight or fight response secondary to anxiety. So what are the different clinical features which we should rule out in our OPD when a child with anxiety comes to us? So parents typically will tell that child appears more clingy than normal. He is very restless and very fidgety. He has all sorts of aches and pains like stomach ache, headache, body ache, joint pain, neck pain, etc. There is disturbed eating and sleeping pattern. The child or teenager gets upset very easily, lashes out, gets irritable very easily, will cry, have unexplained crying episodes, even with minor triggers. And there is difficulty in struggle, in concentration in any of the activities, including school. Apart from these symptoms, the teenagers, they present with constant fears or worries about routine aspect of their lives. There is withdrawal from friends and social activities, sudden poor school performance. School refusal is very important symptom of anxiety disorders. Like many of the studies, they have shown that anxiety and anxiety-related disorders are the most common factor causing school refusals in children and teenagers. Substance abuse is again very important because anxiety will predispose to substance abuse. Substance abuse will develop guilt. That guilt will again increase the anxiety and the cycle continues. So now coming to the assessment of the case, I'm only outlining the 3 points of the assessment, which starts with clinical interview with teenager and parents separately, of course. Lot of open communication, open dialogues, having open-ended questions and showing lot of empathy towards the teenager is important to dig out the important information. So it starts with symptom assessment. What is the onset, duration, how much is the impairment in functioning in daily routines, including academic, relationship, school, etc. Is there any history of trauma, sexual, emotional, physical traumas? Family assessment, this is one of the most important factors because disturbed family dynamics are important to develop anxieties in teenagers. So how many members are there? What is the communication of the teenager with those members? Sibling rivalries, how severe? What is the parenting style? Are there any family stressors or conflict? Even extramarital affairs in parents develop a lot of anxieties in teenagers and children. Use of substance in teenager or any of the family members. Assessment of suicide risk. This warrants urgent referral to mental health specialist. Then comes the role of history of medical illness because there are many chronic conditions which may add to the anxiety symptoms or which have anxiety mimicking symptoms. History of any medications like over-the-counter drugs or medicines for the chronic illness or any herbal medicines, etc. Then comes very important the role of physical examination because it is very important to rule out differential diagnoses which contribute to anxiety disorders or which have anxiety mimicking symptoms. So which are they? Asthma, cardiac arrhythmias, valvular heart diseases, all can cause palpitation. Beta-1 agonists are known to cause palpitations, shortness of breath, diabetes mellitus, hyperthyroidism, substance use effect, alcohol, nicotine, opioid withdrawal, or any intoxication with the stimulant drugs. So everything should be ruled out before proceeding further towards evaluation of the anxiety disorders. And then comes the role of psychological evaluation with different standardized assessment tools like questionnaires, which we'll discuss later.
Madam,
Yes,
can
sir.
I say something?
Yes, sir, please.
PCO is one important cause of adolescent anxiety. So I think in this list of diabetes and all that,
Okay.
you should include PCOS, please. Okay.
Sure, sir. Sure.
Please
Okay.
continue.
Yes. So screening for other comorbid disorders like ADHD, ASD, we have already discussed. Mood disorders or substance use is very important. These are the questionnaires. Here I am highlighting only screening questionnaires for office practice, which are useful for general pediatricians. So one important is Beck Anxiety Inventory. This is freely available online. It has 21 items or symptoms. I have listed few of them. So what we can do, we can take a printout of this. This will take only 15 to 20 minutes to screen the patient. And if you found any symptoms of anxiety are there, then please refer the patient to adolescent mental health specialists. The other is SCARED questionnaire, screen for child anxiety related disorder. This is again freely available. We can use any of them and you can take a printout and put it under your glass table in the clinic and use them whenever required. So what are the different referral criteria for teenagers with anxiety symptoms? So first, if the symptoms significantly interfere with the daily functioning, relationship and overall well-being, if symptom persists for extended period or worsen over time, if there are concerns about self-harm, suicidal thoughts, I have already said that this is an urgent indication for referral. Severe aggressive behavior or eating behavior which is out of control, school refusal, when a child with chronic medical condition demonstrate behavior which interferes with the treatment of that condition. So many times children with chronic disorders, they develop anxieties. Coming to the management, it is of course a collaborative decision making with teenager, parent, and also school. So school teachers, principals, involvement of peer support group is also very important, counselor and doctor. we develop a treatment plan which is tailored to teenagers and their family needs and their preferences. Prognosis is, of course, improved with early intervention, caretaker support, and professional collaboration. So, cognitive behavioral therapy and pharmacotherapy are the mainstay of management. Cognitive behavioral therapy is based on thought, feeling, action cycle. Pharmacotherapy mainly includes selective serotonin reuptake inhibitors and other drugs. I am not going into detail as Dr. Prachi Birari will be taking it in detail. So, for mild conditions, monotherapies are sufficient. For moderate or severe conditions, usually combined therapy is preferential. And these are the key recommendations. So, cognitive behavioral therapy and SSRI should be offered to patients aged 6 to 18 years of age group for any type of anxiety disorder, be it a social anxiety disorder, GAD, separation anxiety disorder, or specific phobias or panic disorders. So, in short, about cognitive behavioral therapy, this is basically a self-talk teaching therapy. It is done by trained therapists. It has two components. One is cognitive restructuring, where we assist the teenager to identify the maladaptive thoughts and change them into adaptive ones. So most of the time when there is heightened anxieties, the thought process is like, I can't do this at all. This is very overwhelming for me. I'm going to fail. So all these thoughts are identified, validated, and changed to the thoughts like, I can do this. It is okay to be anxious, but I can still give a try. So all this thought processing is changed from maladaptive one to adaptive thoughts. Second is behavioral component, which includes teaching various relaxation strategies, giving repeated exposures. So these are all the mood lifting strategies, deep breathing meditation, how breathing works. So taking slow breaths will slow down the release of stress hormones, having positive self-talk or positive affirmations. And there are many others. These slide is just for example. Like teenagers, as per his or her preference, may choose any of the hobbies like cooking, gardening, being in the company of nature. So all sorts of relaxation strategies can be used. Then comes the role of family therapy. This is again very important because parents may inadvertently maintain or increase the anxiety. So providing psychoeducation is very important. As parent and teenagers, they should have trust in your process, in the treatment. So identifying families' problem-solving skills, conflict resolution skills, changing the destructive patterns to more constructive one, teaching assertive communication skills, various emotional regulation skills, etc. are very important in family therapies. One of the studies have shown that maternal empathy is one of the most important factor in management of anxieties in children and teenagers. So I think this was in short about the GAD. Now coming to next part, that is specific phobia disorder. As the name suggests, there is irrational fear which is out of proportion to the danger. There are two types, simple phobias and complex phobias. This is a DSM-5 criteria for phobia. I'm not going into detail of this. So let us have a look at this case. She's Soumya, 17 years old student. She is experiencing increasing difficulty attending the classes and going out alone for social activities. She often avoids leaving house and feel extremely anxious when faced with prospect of going out in public. So what is this? This is known as agoraphobia, that is fear of open spaces. And these patients, they usually present with panic attack in open spaces. And once they develop panic attack, they become extremely anxious that there is a lot of anticipatory anxiety. What if I go out in crowded places and I develop panic attack there? How I'm going to manage myself? What other people will think of me? So better is to avoid such situations. So they avoid situations like being alone, being in crowded places such as busy restaurants, supermarkets, traveling on a public transport, etc. So they might lose their job. They might lose going to office, going to college. So they are missing many opportunities, and this is one of the severe condition which warrants intervention. So how a typical panic attack occurs? It is unexpected. It usually lasts for 10 to 15 minutes, and there is sudden onset of palpitations, sweating, sense of dread, sense of suffocation, loss of control over their breath, swallowing, speech coordination. They feel as if I'm dying, I'm losing control of myself, etc. They'll faint down, they'll cry out suddenly. So typically, these patients, I have one patient recently, she's staying in a hostel and she said to me, when I develop this kind of attack, I usually go and hide in a cupboard of the hostel. So they have a lot of anxieties about these attacks. Coming to the other categories of phobia. So these are the 5 categories. One is natural environmental phobias. Animal phobias, this is again very common. So dog phobia or spider phobia, frog phobia or cockroach phobia is very important. Many times when a cockroach comes in front of us, we just yell out. Mutilation or medical treatment phobias. So we have seen some of the teenagers, they fell down when they see injection or see blood. Situation phobias, agoraphobia is one, claustrophobia is one more important situation phobias. So how these phobias they present? So first, very important is the avoidance. They'll just avoid the trigger. Then they may present with symptoms of anxiety, which we have already discussed. And the third one is panic attack. These are the different methods of treating phobia. So when should we treat? When they are impairing the daily functioning. So the various methods are cognitive behavioral therapy is very important. We already discussed. So identifying and challenging the irrational thoughts related to phobia. Exposure therapy. So giving graded exposure to the phobic stimulus in a controlled environment. Systemic desensitization. This combines the graded exposure with the relaxation techniques. Virtual reality therapy. This uses the virtual reality technology to simulate the realistic environment. I'm not aware whether it's available in India or not. Medication therapy combined with the other therapies may work for severe conditions. I would like to highlight more on systemic desensitization because this is an evidence-based therapy for specific phobias, not only for specific phobias, but also for OCDs and post-traumatic stress disorders. So what is the principle basically? The original fight or flight response of sympathetic nervous system in anxiety is replaced by relaxation response of parasympathetic nervous system. So there are 3 steps. First, identify the phobic stimulus, build a fear hierarchy. Second, teach relaxation techniques to a person. And third, graded exposure to the phobic stimulus combined with the relaxation techniques. So the fear response is replaced with the relaxation technique. Take an example of dog phobia. Suppose a child is phobic to dog. So how we'll build a fear hierarchy? Initially, we'll just show a picture of dog. We'll ask him or her to describe a dog. Then next time we'll take a small dog. We'll build a story or we'll ask the child to play with that dog toy. Then next time we'll take a big soft toy. We can build a story. So this guided visualization that the child is playing with the dog. So we can build many stories and ask the child to interact with the toy dog and, then next will be showing a puppy from distance and then going to the puppy and play with the puppy. And the last step will be petting a dog. So all these fear hierarchies build up and their systemic desensitization is done step by step in specific phobias. So I think with this, I conclude with my talk with the take-home message that prevention is the key factor for mental health disorders. Early identification and early referral to adolescent mental health specialist improve the outcome. Use of screening questionnaires in office practice is an easy tool for screening anxiety disorders. CBT and pharmacotherapy are mainstay of management for generalized anxiety disorders. Systemic desensitization is evidence-based therapy for specific phobias. So prevention is the key factor. Just heard of talk of Padma Shri Dr. Bafna 3 days ago, where the talk was about incalculating family values in teenagers and children. And very beautifully he explained how the family values, they protect the teenagers and children from development of various mental health disorders. So I think this is something which the present cyber generations are missing and should be consciously practiced by society and parents. Cultivating positive emotions like empathy, compassion, gratitude works well. Developing healthy lifestyle, developing responsible digital behavior. Parental connect is again very important in protection of mental health disorders like anxieties, nurturing different hobbies, relationships, skills, and the list is, I think, endless. So with this, I would like to conclude. Thank you so much.
Thank you so much, Dr. Tripti ma'am. It was a very concise talk on anxiety, phobias, and there are certain things that we always think of anxiety as a separate entity. But today we got to discuss the spectrum which the anxiety and the anxiety disorders hold. Plus, the general anxiety mimicking organic issues which you pointed out. So I think it makes sense to look at it in both the perspectives and then go ahead with the management. Ma'am, there is one question in the chat box, if you would see. It is by Dr. Anil Diwan, sir. How far do you think is a single child factor important when it comes to anxiety issues in kids?
Yes, it is important because, there are other factors like sharing, having companion are important. Human is basically a social animal. So being social is very important to protect our mental health.
Right.
So in these era, when there are nuclear families, when both the parents are out, when there are no grandparents, there should be someone to share our thoughts, sharing and having, someone with a trust to bring down that mental stress is very important. So yes, single child is an important factor.
Okay. Okay, ma'am. I can see Amol Kaur sir also has joined our session. I think Sulba ma'am is there with us. Welcome, sir. So I think
Sir, kara
sir
unmute.
is
Sir, kara आता करा. Sir, आता करा unmute.
Yes, thank you, Pallavi ma'am, thank you, Sonali, thank you, Trupti.
So
Atul Kanikar sir, good morning sir, it was a nice session. Yes,
तुम्ही कायम गाडीतच असता का?
actually executive board meeting होती,
तुम्हाला कोणी घरात
तर
घेत नाही
दार्जिलिंगला
असं
आता
आहे का? Why is it
दार्जिलिंग
that you
चाललोय.
always in the vehicle? Actually, Trupti madam, I had asked you one more question in the chat box. If Sonali madam has missed it, let me ask it openly. How do you teach a teenager to understand what is normal concern, which is productive, and abnormal anxiety? How do you teach? What do you ask to a teenager? When do you conclude that this is not just a concern, it is, clinging towards anxiety? So please tell me.
Yeah. So we had already discussed about healthy anxieties and unhealthy anxieties. So basically, we should first teach the teenager or child to identify the emotion, the feeling fingerprints of the emotion. So when there is anxiety, the feeling fingerprints are usually, being very much restless, having butterflies in the stomach and so on, having sweaty palms and etc. So these feeling fingerprints should be taught by us. And then what is the severity? So what is the impairment of that anxiety in your daily routine? Like sleep,
Okay.
like your diet, right? Involvement in your routine activities. So if that is impaired, then that is something unhealthy and teenagers should seek for a help. If they are not hampering the daily functioning, then
So
it is, yeah.
basically, that is what we have been telling our pediatricians, that anything, any problem, any issue that lasts beyond 2 weeks, it affects your sleep and appetite. It affects your daily functioning, schooling, needs immediate concern, immediate treatment, something like that. So this same thing applies to anxiety also, that in our office practice, we have to teach, we have to ask how long this has been there. If the child says it was there for a month or 2 months, then there is definitely a problem. But if it was recent, like, our speakers many times when they are on the mic, they get a temporary, I won't call it anxiety, but definitely a concern that they keep on getting worried about it. But if it is temporary, fine, well and good. But if it affects your sleep and appetite, your daily functioning, your family relationship, your irritability, it needs immediate intervention. And that can be done through CBT and definitely pharmacotherapy, which Prachi madam is going to teach us today. Nima madam, namaskar. So over to you, Sonali madam.
yes, sir. So after a very concise and very clear talk on the anxiety and anxiety disorders, now let us move on to our next session for today. Let me welcome today's second speaker, Dr. Prachi Virari. Dr. Prachi ma'am is a consultant pediatrician at Shri Ganpati Hospital, Nashik, as well as working as a pediatrician at the NMC Hospital in Nashik. She has been successfully managing her post as treasurer of Nashik IAP for 2 consecutive years now, and also is an EB member for the women's wing of Maharashtra IAP. She is a co-chairperson for the Mission Pink Health, which is a national project for prevention of anemia in girls, which has been running under the IMA Nashik banner, and has been actively involved in many of the IAP activities as well. So I welcome Dr. Prachi. Ma'am, can you please start your session, ma'am?
Thank you. Thank you so much, Sonali, for wonderful introduction. At the outset, I would like to thank our President of MahaIP, Ram Gopal Chezara sir, Amol Pawar sir, our mentor, Dr. Atul Kanikar sir, for giving me this opportunity to present myself on the virtual dais. Thank you. Thank you so much, sir. Let us start with our today's topic, which is first topic is pharmacotherapy in anxiety disorders. I think it's visible to all, Sonali.
Absolutely.
Yes,
It's
yes, it is.
Yes. Let us start with the pharmacological management of anxiety disorders. In a broad spectrum, we have 4 to 5 categories of these anxiolytic agents or for the which are used for the management of anxiety disorders. First and foremost, the very commonly used in the first line management are SSRIs, that are selective serotonin reuptake inhibitors. These are the first line of drugs which are used in anxiety disorders nowadays. That is because they are very well tolerated. They treat the comorbid depression. There is very low risk of mortality, even if there is a little bit of overdose. And the negative points in that is they little take a more time for the onset of the action, that is 4 to 12 weeks, and the symptoms may worsen initially. Even the teens or the kids may have suicidal tendencies once you start SSRIs. So you always have to tell the parents or that one person has to accompany the child when the patient is on SSRIs. The commonly used SSRIs are escitalopram, citalopram, fluoxetine, sertralins. Next in the list is tricyclic antidepressants. Tricyclic antidepressants, the positive point for using them is they treat the comorbid depression, and the side effect for that is cardiotoxicity. They may induce arrhythmias. They have anticholinergic side effects like dry mouth, urinary retention, then decreased temperature of the body. There is always a risk in overdose. The next category is benzodiazepines. They are never used singly. They are always used as adjuvants. There is a quick onset of effect and they are very well tolerated, but there is a side effect of sedation. There can be a rebound anxiety. There is the risk of dependence when you are using benzodiazepines. Next are MAOs, that are monoamine oxidase inhibitors. Monoamine oxidase inhibitor, they treat the comorbid depression. If the child is suffering from depression and other anxiety disorders, you can use this alternative therapy. But you have to be very cautious. You have to advise the patient for using a low tyramine diet. What is low tyramine diet is you have to tell the parents not to give the child dairy products, cheese, and over-ripened fruits. And there is a risk of hypertensive crisis when you are using this. RIMA is reverse inhibitors of monoamine oxidase A. They are comparatively better than MAOIs. They reduce the dietary restrictions which were there with MAOIs, but they are less effective than the previously discussed drugs. Some of the anticonvulsants are also can be used as the adjuvant therapies for that because they have the quick onset of effect. But there is a less evidence associated with these drugs. They can cause sedation. Some of the anticonvulsants which can be used in anxiety disorders are tiagabine, then lamotrigine, topiramate, certain anticonvulsants which have GABAergic effects like gabapentin, then pregabalin, they can also be used. Here you can see the commonly used SSRIs, their doses, and the most commonly used is citalopram, escitalopram, and fluoxetine. The doses, as you can see here, are different for each and every drug. Commonly used ones are citalopram, escitalopram, fluoxetine, fluoxamine, paroxetine. SNRIs are the second group of drugs which can be used. They are serotonin norepinephrine reuptake inhibitors, increase the levels of serotonin as well as norepinephrine. The example for that is duloxetine, venlafaxine. The doses, as you can see on the screen. SSRIs, which are used in different disorders, are there on the screen, and this is a generalized overview of all the pharmacological agents which are used in the treatment of anxiety disorders. The first line of therapy in panic disorders are SSRIs and SNRIs. Generalized anxiety disorders, again SSRIs. Social phobias, SSRIs. The first line management almost in everywhere is your selective serotonin reuptake inhibitors. Alternative therapy and adjuvant therapy can be used depending upon the needs of the patient, though this chart cannot be visualized clearly, but can be, I will share if anybody wants. Please put it in the chat box, and let us move on to our next presentation, and that is post-traumatic stress disorder.
The chart was quite visible, madam.
Was that, sir?
Yeah, actually it was. Okay, you carry on with your next presentation.
If time permits, I'll take it again, sir, at the end.
No problem. You carry on with your. My one question till you browse through your presentation. Can I?
Yes, sir. Yes, please.
How do you relieve the anxiety of a child who has to prepare for a public speech next week because some chief guest is coming to the school? What medication would you recommend?
Sir, first of all, I'll counsel the child
Okay.
rather than starting with any pharmacological agent.
Okay.
Then, depending upon the child's symptom, if because of the anxiety, if the child is not able to sleep at night, and that is hampering the day-to-day lifestyle of the child, functionality is affected, I will need an agent which will give an immediate effect for a shorter duration. So
Okay.
I would go for the combination of SSRIs plus benzodiazepines or the benzodiazepines alone. I think,
Or
sir, you can.
if any child says ki, before going to the exam I am tremendously nervous, my hands tremor, I have a lot of sweating. Can you recommend a beta blocker?
Yes, sir. Actually, nowadays we use the combinations of beta blockers plus benzodiazepines. That combination is also available, so we can use that in those patients.
Okay, so typical performance anxiety, the medication would be a beta blocker. That is what I want to confirm from you.
Okay, sir.
Okay.
Let us start with our next topic, that is post-traumatic stress disorders. Post-traumatic stress disorder, as the name suggests, it's a health condition which can develop in response to traumatic experience such as life-threatening experience or which is an extremely distressing situation. And that causes intense fear in the child, horror, or the sense of helplessness. As Dr. Tripti has already mentioned, the incidence of all the anxiety disorders is on rise. The incidence of acute stress disorder and PTSDs is also on rise. We can say 8 to 10% of all the exposed children and 16% of the exposed children every year develop post-traumatic stress disorder, or we can say ASD. Now, what trauma triggers the development of post-traumatic stress disorders are listed here. Trauma can be any sudden threat to the life or physical integrity of the child. Now, this trauma can be anything, just a car accident, the airplane crash, a violent crime, a sexual abuse, rape, then natural disasters, physical abuse, and any experience where the child feels that there is threat to the life and he may get killed can accentuate the series of events. There are certain factors before the trauma and after the trauma which can predispose the child for developing PTSDs, like female gender, low intelligence, then decreased self-esteem, poor socioeconomic status, the series of events which have taken earlier in life which can lead to development of PTSD later on in the life. And after the trauma also, if there is decreased support from the family, then again the trauma is repeatedly happening, then the child can have PTSD. PTSD, we have 5 different categories. First one is a normal stress response, acute stress response, then uncomplicated PTSD, complex PTSDs, and comorbid PTSDs. What is there in normal stress response is just a normal reaction of the child to any form of stress or any form of trauma, which lasts for few hours, but it gets recovered with the proper care and counseling and support of the child. Does not last long. Acute stress response usually lasts long, but in days, but less than a month. For acute stress response, also repeated counseling of the child is required, but these children recover very well within few days and less than a month. As far as PTSD is concerned, and to label a child as having as suffering from PTSD, the symptoms have to be there for more than a month. And in uncomplicated PTSD, they are lasting for more than a month, and single trauma is causing PTSD. Complex PTSDs there are various factors or various triggers and traumas which are leading to development of PTSD. Comorbid PTSDs are already the child is suffering from some mental disorder, the child was having anxiety or depression or any other kind of psychological problem and now is suffering from PTSD is labeled as comorbid PTSDs. As Dr. Trupti has already discussed, body is releasing certain hormones and making yourself ready for any kind of emergency reaction, like adrenals are secreting norepinephrine, epinephrine, there is ACTH secretion, there is cortisol secretion, which is leading to increased blood flow in the lungs, increased heart rate, inhibits the urination, there is release of glucose, there is dry mouth, there is decreased salivation, and there is shaking and trembling of hands. Now, some of the symptoms of PTSDs in general are nightmares, flashbacks, avoiding reminders, forgetting the important aspects of the traumatic event, unable to experience the positive emotions, irritability, angry outbursts. See, these symptoms have been classified into intrusive symptoms, avoidance symptoms, heightened arousals, and changes in the thoughts and feelings. What we call as DSM criteria has classified all these symptoms, and there is a specific DSM criteria for PTSD. Criteria A speaks about the trauma exposure. The child is exposed to the trauma, or the child has witnessed the trauma which is happening to the other person, or the child has heard about the trauma. This is more common in health professionals who are giving help to others, but they themselves are exposed to the trauma indirectly. So any one of the trauma triggers has to be there. Criteria B speaks for intrusion symptoms. Intrusion symptoms, any one of the symptoms has to be there, like the child constantly keeps on getting the nightmares, flashbacks. He constantly keeps on thinking about the event and the series of events which has happened to him. Criteria C speaks about the avoidance symptoms. Avoidance symptoms also has to be one. The child avoids getting into the same situation, talking to the people who were involved in trauma, or he's trying to avoid the atmosphere where the trauma has happened. Criteria D is altered mood and cognition. Basically, negative symptoms predominate over here. Negative symptoms, 2 symptoms have to be there for this to be labeled as PTSD as well as per DSM criteria. Negative symptoms like always having negative thoughts, not getting social, decreased scholastic performance, then decreased interaction with the family members. Criteria E is hyperarousal symptoms, where the child is not able to sleep properly. He is constantly will wake up at the night. He is sleep deprived. He is agitated. He is restless. Sometimes there is what you say destructive behavior on the part of the child. So that also comes in the hyperarousal symptoms. 2 of the symptoms have to be there to label it as PTSD. Criteria F is the duration of all the symptoms have to be there for more than a month. And criteria G is all these symptoms, they affect the functionality of the child and they are so much significant. They interfere with the day-to-day activities of the child. And this is the DSM-5 criteria for PTSD. How you can help the child for PTSD is always listen to the child when they are ready to talk. Never ever force the child to talk, because instead of helping the child, that will worsen the situation. Reassure that the traumatic event which has happened will the child will recover from that. Remind them that they are loved. Closely monitor a person. let them know that they are important. While you are interacting with the child, the heads criteria you have to apply. Heads criteria is ask about the home of the child. Like who do you live with? Who is closest to you in your family? What is your relation with other family members? And ask about the education, that how is school going on? Who are your closest friends? Then how is your relation with your teacher? Are you happy with your school? Are you happy with your teachers, your friends? You have to ask about the activities, alcohol, like what you do in your leisure time, like what all activities are liked by the child. Have you ever experienced intake of alcohol? What are your friends' views about alcohol? What are your views? And you ask about the diet of the child, drugs, any positive clue you get from drugs, like what kind of diet the child prefers, what he eats every day. Drugs also, have you ever heard of ecstasy, marijuana? Are you taking them or any of your friends are taking them? Then self-esteem, sexuality, S stands for the self-esteem is what do you feel about yourself? Are you happy about what you are? What are your views about sexuality? Like, have you ever had physical contact with anyone? What is your definition of being normal sexual contact? Then safety and suicide, are you taking care of yourself when you're on bike, or what is your definition of safety? Then suicidal tendencies, have you ever thought of committing suicide or causing any kind of harm to yourself? You also have to be very keen about taking school histories. You have to ask about school absenteeism, decreased school performance, decreased interaction with friends. The child is getting easily irritated. There are problems with the school disciplines, and he's just avoiding peers, and the grades are dropping. So when you're helping the person who are the child who is having PTSD, you have to remember all these things, that never ever give a false assurance that once you tell me everything, nothing will happen to you. No, don't give false assurance to the patient. Then never blame the person for the traumatic event, that if you would have done this, such thing would have not happened. Never ever say that. Then while taking the personal details, you go and ask open-ended questions. Never use the words that minimize the person's experience or feelings. Never force the person to talk about the traumatic event. As and when the child is ready to talk, you should listen. Coming to the management of post-traumatic stress disorders, there are, as Dr. Tripti has already spoken about it, I'll not go into the details of it, but the cognitive behavioral therapy, that what we call as CBT, is the mainstay of the treatment. Another therapy is exposure therapy. This is used to teach the people to have less fear about the memories. Play therapy, which we use in younger children, eye movement desensitization and reprocessing, and evidence-based treatment, that is those patients who are not improving on behavioral therapies, we go for adding pharmacological agents. As we've already discussed, SSRIs are the mainstay of the treatment. Another adjuvants which we can add are the benzodiazepines. Antiadrenergics are never used in this case. The most important thing, if the child is deteriorating, the symptoms are not improving, there are suicide tendencies, then you have to refer the child. It's altogether a multidisciplinary approach with the involvement of psychologists, psychiatrists, and occupational therapists. I would just like to discuss a case we had. There was a 10-year-old male child who was brought to OPD with on history. We found out that the child was brought up by the single parent. 3 months ago, the child had fight with close friends in the school. Same day, teacher also punished him by making him stand outside the class for an hour. Since then, this was almost 3 months ago. Since then, the child is not able to sleep properly. His appetite is decreased. He's not ready to go to the school. His social interaction with his friends has decreased. There is a decreased appetite, and this child was brought to us in the OPD. As per DSM-5 criteria, we could find out there were intrusion symptoms. Child had hyperarousal. There were positive school history, and all the points in the history pointed out that all the symptoms lasted for more than almost 1 month. This was going on since last 3 months. So we could label this as PTSD. The child was started on escitalopram and CBT. On escitalopram, the symptoms were not getting relieved. At night, the child was still having insomnia. He was not properly able to sleep. So psychiatrist was involved in the management, and paroxetine was started by the psychiatrist. And I must tell you that this has been 6 months. We've started the child on this, and child is doing really very, very well. There are no symptoms like flashbacks, nightmares, and not able to sleep properly. The grades in the schools have also improved. The child has again become social, interacting with friends and living a normal life. So this ends our PTSD, and now we'll go for psychosomatic disorders.
Dr. Prachi, there's the question in chat box by Atul sir. By the time that we are changing the PPT, could you please answer that?
Yes.
So sir wants to ask, would you recommend that we include the DSM-5 criteria for PTSD as a routine questionnaire for heads?
Of
Do you
course,
think that
of
would
course.
help?
Of course, sir. I think it should be employed in each and every case. We should ask the questionnaire as per the heads criteria, and if we classify the symptoms according to these.
Prachi madam, can I ask you for a favor? Can
Yes,
you simplify a questionnaire, especially for PTSD, because that is the commonest mental health problem, anxiety problem, and in that too PTSD. It could be because of breakups, it could be because of bullying or anything. But we are seeing so many PTSD. So can you formulate for all of us a questionnaire and put it, through our messages or WhatsApp or whatever? And these are the questions which will point towards PTSD needing CBT. Now, another question what I want to ask you is what exactly you do in your CBT?
so basically, am I audible?
Yeah, of course.
Yes, sir. CBT basically this is a therapy where the behavior, the thoughts, and cognition of the child. After the repeated counseling, we try to. I think, sir, you please enlighten us more about it.
Oh, no, that is not my domain. I'm a student today. So
Expert like you can enlighten us more about it, sir.
actually, here the case that you told about this 10-year-old boy whom you diagnosed as PTSD, I think he was more revengeful on the teacher, on the friends, or whatever. So you need to tackle that unhealthy negative emotion and convert it into a healthy anger. Medication comes much later. Medication comes much later. As a practicing pediatrician, as Prachi madam and Supri madam has said about empathy, if you were in the child situation, what would be your emotions? That needs to be identified. And that will take you near the diagnosis, whether the child needs only CBT counseling or REBT or then medication. Medication is the last treatment that we have. And main thing in our day-to-day office practice is one-to-one talk. And that is what most of us are missing in our daily practice. So we need to focus on this as pediatricians, as adolescent care experts, that one-to-one talk to a child, with a child in the absence of parents, because in the presence of parents, parents dominate the show. So we should have a separate time, separate talk, maybe 10-15 minutes की बाळा तुला काय होतंय, कसं वाटतंय, काय नक्की तुझ्या डोक्यात आलं होतं जेव्हा हे सगळं घडलं तेव्हा. And the child will pour out all his emotions. And you have to filter out healthy negative and unhealthy negative emotions. And then you can intervene. याच्याने खूप फायदा होतो. I have witnessed this, I have seen this in my office practice, that once you have a one-to-one talk, you give your listening ear to the child, and that dissolves all the stresses in the child instantaneously. The child knows that there is at least someone who understands my language, understands my emotions. हे आपल्याला pediatrician ना या महाआयपीच्या program we have to percolate this, and if the office bearers agree, we will continue with this. That this is very, very important. So over to you, Prachi madam. Please continue.
Yes, sir. Yes, sir. The last topic for today, and that is a psychosomatic disorder.
Dr. Prachi, can I
Yes,
just have one small query because it goes into the flow as Atul sir just said that we are looking at the pharmacological therapy as a not as a primary modality. We go over to it after doing all the other non-pharmacological interventions. So someone in the chat box has asked a question which is very pertaining to it. That once it's by Dr. Bharti Gurnani that how do you decide that when the SSRIs are started for anxiety disorders can be stopped? Like what would be your criteria for stopping them and how would you go about it? Like tapering or what would be the plans? So how do you suggest, Dr. Prachi?
SSRIs usually take a longer time for them to act upon, so we need to wait for almost 4 to 8 weeks for SSRIs to act upon. So once that after the child improves symptomatically, the child's what you say flashbacks are decreased, then the child has if the poor scholastic performance is there, the child has started improving socially, is trying to interact, that which we can see in the behavior of the child. I think the doses can be tapered after 2 to 3 months of the treatment. But if the child is not improving and the situation is worsening, then I would go for involving psychiatrist or psychologist in this rather than me treating the disease alone.
There's one more comment from my side, madam, if you allow.
Yes, sir.
Whenever you use antipsychotics, please do not prescribe yourself. Antipsychotics need, there are different types of drugs. So psychiatrist prescription is necessary. So do not prescribe antipsychotics on your own except risperidone. Risperidone can be safely prescribed, but otherwise SSRI you can safely prescribe with, as Prachi madam said, suicidal, accentuation or thoughts with the parental involvement. It has to be given with 24-hour supervision by the caretakers, at least in the first 2-3 weeks, where the suicidal ideation can be accentuated and the child can actually go for a attempt. Okay. So over to you, Sonali madam.
So I think Dr. Ratna Parki sir wants to also add his comment.
Please.
Dr. Sanjay sir?
Audible?
Yes, yes. You muted yourself, sir. Please unmute.
Unmute, sir. Unmute. एकदाच करा.
Sir, we are not able to hear you. You are still muted, sir.
तुम्ही मॅडम समोर असल्यासारखं दोनदा स्वतःला अनम्यूट करू नका, एकदाच करा. त्या लाल याच्यावर आता बोला.
Hello.
Yes, sir.
So, good morning, everyone. I just want to reorient this concept of the anxiety. Basically, what is anxiety? Anxiety is the dysregulated sensation which comes in the child or anybody when there is a threat, just like actual, but it is not real threat. Just you said, Kanikar sir, public speaking. Public speaking may not be a threat for person, but for that child, it is a state, and it is a severe brainstem survival reaction, palpitation, threatening, which may come anywhere. So simply giving medical therapy or even cognitive behavior therapy may not be so much useful, because there is a new branch which is coming called as embodied psychology, where you deal the person to deal that disturbance in a very titrated way. And the therapies which are there is somatic experiencing, integral somatic psychology, EMDR, where you are even brain spotting. So what you do here, you expose the child in a very titrated way. By creating a positive resources. Resources means when you are a person, you are living with this particular problem. Do you want to live in the same pattern? If your answer is no, then I am going to expose to little evidence, a little anxiety like this here, and see what happens in the body and allow it to come downwards. This is what is the body-based psychotherapy. Then again, the person is taken into a slightly more, and then person is allowed to settle. And then we go into layers of the trauma, deeper and deeper. And a stage comes, person understand, develop the internal resources, and also a stage comes, person can manage the anxiety on its own basis. And then the result become more competent, more permanent, because the reins are in the hands of the child. Problem with our therapy is that reins are in the hands of the therapist. And when reins are in the hands of therapists, the things will not happen permanently. So these are new views.
I actually agree with whatever Sanjay sir you say. You have given a very good insight into this talk. Maybe in the next mental health session, we will have you as one of the guest speakers. No problem. You are most welcome. We would like to learn from you. But what you are trying to say is our own contribution to anxiety should be taught to the child rather than the stimulus. You are with me on this? Do you agree or not? Sanjay sir, I am talking to you. Yes, okay. नाही तुम्ही अंगठा दाखवताय. अंगठा दाखवणं मराठीमध्ये थोडंसं वेगळं असतं. पण this is something which which is included in the CBT or REBT or whatever therapy that we give, that your own contribution to the trigger is something that is accentuating the end result. That is the consequence of your behavior, thinking and feeling. Okay. So fine. Sonali madam, please
Yes,
go
sir.
ahead.
Dr. Prachi, please you continue.
I think we have to go to the next talk.
Psychosomatic is, I'll just say, cover it in 2-3 minutes, sir. Is
Okay.
it fine?
Okay. But
So
we have
psychosomatic
hardly
lecture.
5-10 minutes for Nima madam. She is waiting for a quite long time.
Okay, sir.
So
If
should
he
I
wishes.
conclude the talk, sir?
No, it's okay. You go ahead. Whatever is important, please tell.
Okay, sir. So let's talk about the psychosomatic disorders. 10 to 25% of the children and adolescents are reportedly having psychosomatic problems. What is a psychosomatic disorder? Is when the bodily symptom is not consistent with a definite physical sickness, is what we call as psychosomatic disorder. The incidence is, of course, increasing nowadays. Psychological somatization becomes a problem when the symptoms significantly impair the patient's emotion, behavior, and functionality, and they affect the day-to-day activities of the child. Anything of this is labeled as psychosomatic disorder. There is a disproportionate and persistent thought about seriousness of one symptom. The person is constantly thinking about the seriousness of the symptoms. That is so much excessive that so much energy and the time is wasted in it. Persistently high level of anxiety about the health or symptoms. The state of being symptomatic is persistent and entirely it results in significant disruption of daily life. Etiopathogenesis, all these factors are contributing to the development of psychosomatic disorders. They are genetic, environmental, biochemical, psychological, chronic physical illnesses predispose the child to have this. Mental subnormalities also predispose the child for developing psychosomatic disorders. Stressors in school, child with already comorbid conditions like anxiety, depression, substance abuse, child belonging to broken families, mental issues in parents. The clinical features for psychosomatic disorders, the most common clinical feature is pain, any kind of headache, then stomach pain. The child is fatigued all the time. There is altered appetite, lightheadedness, insomnia, constipation, agitation, elevated blood pressure, gastrointestinal problems like constipation, diarrhea, tachycardia, chest discomfort, sweating, mood fluctuations. The differential diagnosis for this is going to be factitious disorder, hypochondriasis, generalized anxiety disorders, mood disorders. Whenever the child is coming to you, of course, as per Head's criteria, again, we'll take the history of the child, and management is again the skillful questioning to the patient and their families. Of course, as a pediatrician, we should strongly oppose any kind of additional diagnostic tests which are put forward by the patient's relatives, mothers and fathers, because that ends up doing nothing but doctor shopping, and we don't come to any kind of conclusion with that because all the tests and everything comes to be normal. We must positively convey the diagnosis as per DSM criteria and involve other therapists like child psychologists, educators, sport trainers, psychiatrists, occupational therapists in the management of psychosomatic disorders. For the psychosomatic disorders, we don't actually go for pharmacological treatment until and unless the child is having psychiatric comorbidities. Psychotherapy, the motto or the aim behind psychotherapy is to restore and refocus the attention away from the symptoms and restore the social functioning by the child. Adjuvants like major opioids, analgesics, and are usually ineffective. Play therapy can be used in younger children. Family therapy, again CBT, relaxation techniques are employed. If left untreated, all these things lead to unable to pursuing the hobbies, unable to practice the sports, school absenteeism, poor social skill, excessive financial burden on the family, because every time going to a doctor, doing investigations, ends up in spending lot of money on that. Significantly, there are higher adverse life events and lower self-esteem. Prevention is the most important thing. How you prevent these things is the recreational activities. You should give time to yourself, do whatever you feel happy in, get engaged in music, watch some TV, keep yourself hydrated, take healthy diet, spend quality time with family, and all these things I think contribute to proper healthy lifestyle and avoid anxiety disorders. Thank you. Thank you so much.
Fantastic.
Thank you so much, Dr. Prachi. We have had a great session with you today, and I think without any further, because we have mostly discussed all the questions related to the topic, I request anyone who has any other questions to just post it in chat box. We'll take it at the end of the session. So now let me just welcome our next speaker for today, Dr. Nima Sitapara ma'am. Actually, I also, ma'am, have been personally looking forward to your topic since the time that we read the topic name. So let me just give a short introduction of Nima ma'am. So ma'am is a director and consultant pediatrician and adolescent health specialist counselor at Ma Sharda Childcare Hospital at Rajkot. She has done her post-graduation diploma in adolescent pediatrics as well as her post-graduation diploma in clinical hypnosis. And she has been using her knowledge and the skills in successfully managing children and youth with the psychosomatic symptoms. She has many articles and awards to her credit, and she has been a national faculty as well as an author. We can't wait to hear from you, ma'am. Please, over to you, ma'am. Thank you.
Thank you so much. Thank you so much. First of all, I would like to thank IAP Maharashtra and Nashik for giving opportunity to an outsider. I am outsider to your family, but thanks. In this 10 to 15 minutes given to me, I will be giving a brief overview of hypnotherapy and how we use hypnotherapy in children with anxiety disorders. Let me take a case of Raj, who is completing 11th standard this year, and he's having complaint of episodic headaches since last 3 to 4 months, and he's getting nervous. He's entered 12th and he's getting nervous before his major test, NEET mock test, every time when it is taken every 15 days. So this is the routine patient of performance anxiety or academic stress that we face day to day. So first question when the parents or whenever the patient comes to us is we don't usually talk about hypnotherapy, but they are aware of it and they come to us. And even the pediatricians, they just are so eager to feel what you are doing in hypnotherapy. First question comes is hypnosis achievable for me? मुझे hypnotize कर सकते हैं आप? So I would say that, have you felt anxious anytime? Yes, we all have felt. ऐसा कोई व्यक्ति नहीं होगा जिसने अपनी लाइफ में एंजाइटी फील नहीं की है. So similarly, we all experience the state of hypnosis every day in our life. When? How? Hypnosis is a state of mesmerism. We get mesmerized by so many things. It is as common as anxiety, but since it is used negatively, in a glamorized and glorified manner, and it has been shown on stage hypnosis, and we have heard in the stories that beggar hypnotized the child or kidnapped the child. We have a negative feeling about the word hypnosis. We all get hypnotized when we see the board of 50% sale, when you are in that teeth grinding moment of your favorite IPL team. We all get temporarily mesmerized. So what actually happens in a hypnotic state? It is a state of consciousness where the focused attention is increased. You are so deeply engrossed in an idea that the peripheral awareness reduces. So you pass through an uncritical, creative information processing state of your mind. There is muscle reduction in the muscle tension, the body movements reduced, and your perceptions gets altered. So this happens in the hypnotic state. And what is the difference between clinical hypnosis and state of hypnosis which we show in magic shows or a stage performance? Actually, any person who can induce hypnosis can be called as hypnotist. Usually this is done in the stage show. They use indiscriminate skills for inducing whatever state of hypnosis for fun or just to fantasize, or sometimes this may induce unfavorable artifacts also and psychological harm to the patient. Whereas in clinical hypnotherapy, we are medical professional first. We learn, we know, we understand the process of clinical disease or clinical disorder, even without being a non-hypnotherapist. Means I am a good pediatrician first, I am a good adolescent pediatrician first, I am a good counselor first, only then I can go for hypnotherapy in any disease of child or adolescent. I cannot jump directly to hypnotherapy. So these are the prerequisites of a good hypnotherapy session. Now let us come to Raj again. So what will be our approach to Raj when the patient and the parents come to us? We cannot jump directly to hypnotherapy. As you have learned from Dr. Prachi and Dr. Tripti, we have to go through a systemic approach. Detailed individual interviewing, head screening with the patient, with the parents, what actually factors are causing this headache and anxiety, where are there any irrational expectations from the parents, from the child? Is he overgeneralizing one of the negative experience? Like he said, he had two experiences of getting bad marks in physics, and because of that, he is having fear of physics. So, is he overgeneralizing some of the negative experiences? What is his self-talk? What is his self-belief? Irrational beliefs, disempowering thoughts? We just have to dig down deep into all these feelings and thoughts before we plan any hypnotherapy session with the child. Okay. Emotional need of the pain. He complained of the headache. So what is the emotional need of that pain? Is it just to get attention? Is it a feeling of guilt because he might be wasting 2 hours on playing video games on the phone, where he would be telling the parents that I am studying at night? Okay. Is he a neurotic personality? What is the approach of the family members towards his time management, towards his attitude towards the studying? What are his coping skills, learning skills, understanding of the concepts, his study techniques? We have to dig down deep into all these issues and then identify the factors which we need to work on. So for any counseling session, we have to learn to observe with the third eye, and we need to learn to listen with the third ear. And we cannot skip this stage for any patient. Okay, so after that, we design a session which is according to the interest, according to his hobbies, according to his developmental level. after setting a goal of desired therapeutic outcome, which is common to patients and the child also. Like the father for Raj, father said, आप इसका headache खत्म कर दो, बाकी सब उसका ठीक हो जाएगा, उसका headache ही severe है. We cannot directly jump to the headache. We need to explain to the parents that underlying so and so reasons are there, so and so issues are there. We need to handle those issues first, and automatically the headache is a psychosomatic symptom secondary to the issues. It will get resolved after some time. You cannot directly jump on eliminating the symptom of headache, right? So according to the issues and according to the understanding level interest of the client, we develop gradual sessions of hypnotherapy. Again, this consists of some basic relaxation techniques, some immediate techniques like what to do when he get that severe episode of headache or fear, some immediate technique like deep breathing or shifting his anxiety or nervousness to the fist and just throwing away. So that is a jettison technique we use in hypnotherapy. Ego strengthening. Ego strengthening is a wonderful way of raising the self-confidence and self-worth in a child, that whatever problem you are facing is not a problem of your consciousness. It is a problem of your mind and body, which are the tools given to you by God, and you can help yourself just in nurturing, taking care of your mind and body, and you can get rid of the problem. So the technique should be very problem specific. We use guided visualization, we use pleasant imagination and metaphors. Like for Raj, he was a football player and he was very good at it. So we can use the metaphor that whenever you sit down to study physics or whenever you sit down to write the answers, it comes to your mind, it comes to your subconscious as easily as you see a ball and kick the ball in a right way when you are on the football ground. So these metaphors help him correlate and make associations in a better way. There are sensory imagery conditioning where he visualizes himself as giving the best responses and in a calm and cool manner, giving his best time management and giving his best performance at the exams. There are some dynamic imaginations like to increase focus and concentration, bow and arrow imaginations are there. To feel lightness and get rid of the burden, the butterfly imaginations are there. And there are certain pain management techniques. When there is acute severe pain, how he can immediately reduce the pain perception and reduce the psychological component of the pain. So ultimately what we do is we teach the children to work at the level of their own thoughts and feelings, not directly on the symptoms. Because whatever you feel, however you behave is a result of the thoughts created by your mind. Just as our body is created by the food we take, similarly your thoughts and your feelings create your mind, and you can work on that. And what is the ultimate aim of hypnotherapy? Ultimate aim is converting the feeling of helplessness into self-help, making the client an active participant in the entire process, and getting that worth feeling that yes, I can help myself. Why children are good candidates? Because we see day in and day out, they feel a stage of daydreaming. They are very good at creative thinking, and their analytical process, critical thinking is anyhow less. So they are very good candidate. And once we teach them in a manner, in a language which is common to them as a fun, I never use the term hypnosis. I say it is like acting out, it is like role playing, it is like a mental rehearsal, it is like a fun game, and they very easily get involved in the session and they enjoy the process, and next time they are very motivated and eager to take a new session of hypnosis. So it is a teachable skill, and when it is proposed as a fun game, they are very eager to do that. Basically, what a session of hypnotherapy do is we all are facing daily wear and tear because of the excessive autonomic nervous system activity. And this hypnotherapy sessions, they help to stabilize and balance the parasympathetic activity. And this helps to stop the wear and tear and regenerate coolness and calmness. And this acts as the biochemical changes at our psycho, neuro, humoro, and immunobalance. So there is a biochemical milieu that is created by stress and anxiety, and we help them create a new healthy biochemical milieu so that in the same situation, your body and mind, this complex reacts in a different way. And basically, there is activity of theta brain activity during the session of hypnosis that helps in calming down responses. And since it acts as the subconscious level, whatever other therapy we do, it is at the conscious level. This helps to bring a subconscious change, and this subconscious change remains more permanent and long lasting in treating oneself. And once the child learns the basics of self-hypnosis, he can apply it to the later on problems in his life. So it is not a technique for single symptom or single state of mind or behavior process in a life. He can apply it to the long-term problem-solving situations also. And there are some techniques and tricks to make the good hypnotic suggestions. There are the steps of inducing hypnosis. There are the steps of bringing out the patient. I think it is beyond this purview of getting into the details. I just wanted to give the overview of hypnotherapy and what are the contraindications, like when not to use the hypnotherapy. Certain personality disorders, like if the person is a borderline personality disorder, very paranoid personality, he's always suspicion on what you are doing, severe depression with suicidal ideations, persons with psychosis, it is better we don't use hypnosis, because this can cause more harm sometimes when the child or the adolescent doesn't take in the way which we want to deliver. Okay, so any hypnotic session is a self-hypnotic session. We are just facilitator. Whatever the change is brought about is by the child and the wonderful capacity of the mind of the child. We always congratulate the child for helping himself, and we dissociate or we take a step back from the child that congratulations, you have helped yourself. This creates a very nice feeling of self-help and self-esteem in every child. And they learn to focus on solutions rather than the problems. Okay, so I think this was enough. If anybody has any questions, we can discuss.
Yes, sir. Atul, sir.
I have one question.
Yes, sir.
Madam, can we combine music therapy with self-hypnosis?
Yes, sir. Actually, we use music also, calming music, relaxing music. There are many autogenic training musics which reduces our heart rates and reduces our blood pressure and induce calmness.
Okay.
Actually, hypnotherapy is an extended session of whatever psychotherapy you are using. It is extended CBT, it is extended REBT. We cannot use direct hypnosis to ameliorate any system. कल से तुम्हारा headache बंद हो जाएगा, कल से you feel confident in whatever exam you give, it cannot be used. Even if it is used directly for eliminating any one symptom, it will be a short responding. वो एक week में वापस से उसका problem शुरू हो जाएगा, because he has not learned the other basic skills of problem solving. So it comes last after all the therapies along with other therapies. So sometimes we use medicine also along with hypnotherapy. It is a co-therapy, never a single therapy. And we cannot directly jump onto hypnotherapy. We have to go through the basic principles of counseling, basic principles of detailed history taking, interviewing, isolated with the parents and the child, and then designing the things.
Okay. Second thing is, I remember my own children and my brother's children also. When my mother used to feed them, she used to tell them some stories, you know.
Yes,
And when they were sleepy, she used to, like, tell them stories and she used to sleep. The
yes.
kids used to
That
sleep
is,
nicely.
that
So,
is
what you said is relaxation technique,
yes, where the subconscious mind gets more,
positive imagery, positive
yes,
imagery.
it
And
becomes more susceptible to the suggestions.
yeah, and
And very
actually now
difficult,
nowadays what we are seeing is children sleep with mobiles, they eat with
yes.
mobiles, and
So
actually that stimulates the sympathetic system. Whereas this relaxation and storytelling, it stimulates the parasympathetic, which is helpful for the GI tract.
for very small children, like three to 4 years
Exactly.
children, when there is anxiety, we use a sleep talk.
Yeah.
We teach the mother how to create positive suggestions. In her own voice, we help her record the things and she directly speaks it or put it in a loop
So
when
what
the
I
child.
would request you, Nima Sitapara madam, is that can you make a synopsis and then put it forth to our MahaIP platform so that we can recommend that storytelling while eating, no
Yes,
mobile use 1 hour before going to sleep is a
yes,
better way of life, better
yes.
lifestyle for our children and us also. Is that
Some
possible?
Yes, sir. Some techniques to balance the parasympathetic system
You
because
know
our
it. You know
modern
it better.
lifestyle.
You
Yeah,
know it better, madam. So you
sure,
please
sir.
put some guidelines for us so that we can percolate down to our patients in our day-to-day practice. Instead of showing mobile to your child while eating or TV to your child while eating, instead show some picture books, some stories, something like that, so that the child's parasympathetic system, which is
System is
a
balanced.
GI controlling system, it is stimulated and the child eats well and the child sleeps well also. So can you
And
do
then,
that favor for
yes,
MahaIP?
sir, sure, sure. In a couple of days, I will send it to you. I'll make a
Great.
small template like thing and I'll make it send it to you.
Absolutely, madam. So thankful of you. Sonali, madam,
Yes, sir.
over to you.
So Dr. Sitaram Indani sir has been raising his hand for quite some time. I think sir wanted to ask something to Nima ma'am. Sitaram sir, hello. Uh,
I think he is
yeah,
muted.
okay.
No, he's
Even
there. I think he's invisible, but he is audible. If you can say something.
Sir, his audio is not working.
Okay. Any
Sitaram
other?
sir, audio is not
Sanjay
working.
sir. Sanjay sir has a question.
Sir, yes, hypnotherapy is a really wonderful tool, which our pediatricians should learn. I'm also being trained by the same Dr. Palansar. Palansar Institute there, the Indian Institute of Hypnosis at Charuset University, Baroda. She also trained from similar. We pediatricians should learn because it's very, very useful tool which can transform our own being. Even everybody is benefited, but we are not knowing this. It is not being trained. So it is beautiful. At least I just sincerely wish that our IIP should make these new amendments to inculcate these new therapies. So that will give new ideas for us so that we can give a better adolescent care because our knowledge will be widened, our view will be widened. But it's
And
a
it
really,
is
really wonderful.
such a pleasant tool. The child loves to go through that process.
Sucheta Patil ma'am, Malvatkar ma'am.
Yes, yes,
Yes ma'am.
yes. I agree with Sanjay sir and Nima because I have also done clinical hypnotherapy from same institute of
Yes,
Charotar
he was my
University and
colleague,
Andhra
Sucheta.
Palense, and I and Nima were classmates at that time. So it's a very wonderful tool to use in our adolescent practice and in pediatrics. It's very wonderful. Yes.
Um, So, anyone has any questions regarding the talk today? Because I think the discussion which has happened in between the talks itself has been uh, the take-home messages have all come through the discussion from our experts. So there was just one question which 2 to 3 people have asked. It was about the psychosomatic disorders. If Dr. Prachi is there. Dr. Prachi?
Yes, Sonali.
Yeah, so there are 2, 3 people who are asking, and rightly so. A pediatrician like me also will be thinking in terms of in current era of medico legal practice which is going on. How can we differentiate our psychosomatic disorders from organic illness in office practice? Like especially the patient who is coming with recurrent, say, abdominal pains. So, what would be our practical approach to help the patient as well as help us in our management, like ethical but medico legal management for it? And similarly, the other questions are also in the same line, that would it be a bad idea to rule out differential diagnosis by simple and basic tests? So, what would be your take on that?
Dr. Sonali, I think when such patient comes to us, of course, the basic investigations we need to do to rule out, of course, psychosomatic disorder is the diagnosis of exclusion. We are ruling out the other things and then we are coming to the diagnosis of psychosomatic disorder. So it's not that the patient is coming to us and we are directly labeling the child to have psychosomatic disorder. It's at the end of the history, the clinical examination, the diagnostic evaluations, the child is labeled as psychosomatic. I think there is no harm doing basic investigations. Of course, we should do that.
I think the main message would be that basic investigation, we just have to know when to stop doing it. Because if we go on to the investigation panel, unless we have something clinically
That's what the
like
basic
differential,
investigations we
where
need
you're
to do.
so much thinking in organic.
Sonali madam
Yes,
and
sir.
Prachi madam,
Yes, sir.
we see so many questions, so many patients with vague abdominal pain and vomiting and all that. Okay, so if you just go into the basic history, dietary history, and the history of junk consumption, Lay's, Maggie, biscuit, chocolate, kurkure, ananas, कलिंगड, पेरू हे किती वेळा द्राक्ष होळीच्या आधी किती वेळा खाल्ले 9 out of 10 children will say खाल्ले होते just omit it for 7 days and review the child most of the symptoms are vanished then you can do as suggested by Prachi madam some basic investigations the foremost investigation as of today in the last 7-10 days I would say is urine routine because we are seeing so many cases of cystitis in our day-to-day because of dehydration probably. So get a urine routine done, omit the faulty diet, and most of the children become better. Look for the nails, do devermination. Many of the abdominal pains they vanish.
Sir, I
त्याच्यानंतर
would like to add.
Sorry, madam.
Sir, I would like to add a few points for
Please, madam.
psychosomatic
Yes,
pain.
please, ma'am.
Please,
Okay.
madam.
Usually these patients come changing many consultants. And when you sit with the parents and you talk to them that what is the cause that so many consultants are not able to give any diagnosis. Okay, we need to convince them. And usually these children, when their conscious mind is occupied in other activity, like during sleep, the pain is disappearing. Like they are playing in a video game or watching TV, the pain is disappearing. And a psychosocial history, is there a recent change in school, recent change in housing, recent change in the family dynamics, a new subject is introduced or tuition class is introduced, usually we get something that will explain the pain, the disturbance behind the pain, and we need to convince the parents that if this pain has been due to some somatic condition, the weight of the child should have been deteriorated, the child should have been hospitalized so many times, and they get convinced that this is a pain of the stomach, but not due to problem with the stomach, but problem with the understanding or emotion of the child. So this we need to take time and convince, and most of the time we are able to explain them, and then second step of helping them. because unless the parents are convinced, we cannot help the child.
Yeah, Nema madam, absolutely, I agree with you. But here I wanted to rule out the junk foods as the cause
Yes,
for
that
for
causes irritable bowel. That we need to diet history. That
and they
we
are
need
consuming junks like anything, Lays and
high
Kurkure and all that stuff.
fructose,
So
fat, and salt content diet.
yeah, and all artificial foodstuffs and this Kalinga, that is watermelon, which is injected with so much of artificial colors and sweetness that they are getting tremendous colics, and we are seeing these children from the age of say 1 year to 10 years, almost 8, 10 children we see every day here. And you just ask the history, and the answer most of the times is yes.
We
You
get from that.
omit it for 10 days, the pain is gone.
Yes.
No, it's as simple as then you move on to psychosomatic or investigations or what. So over to you, Sonali madam.
Yes, sir. So I think all the queries of the delegates have been answered beyond the basic question also. We have discussed beautifully. And I think it is time for me to just say thank you for this session. Before the last thank you, I would request everyone to just switch on their cameras for a few seconds. We'll take one group photograph. Today we have had more than 210 is the number, the maximum number that I have seen, which is just on Zoom. So this is not even including our YouTube, which is huge. So I think path is path breaking, sir. Can I request everyone to please switch on their cameras? We'll take one quick photograph, please.
कॅमेरा म्हटल्यावर लगेच सगळे येतात ना खटाखट सेल्फी काढायला. ओके, सुचेता मॅडम गेल्यात. सीताराम सर तर कुठे गेलेत कुणास ठाऊक, ते सगळं ऑन
I
करून
think by the time everyone is switching on the camera, I would, on behalf of Maharashtra IAP, Nashik IAP, and Nashik AHA, I would extend my heartfelt gratitude to all our esteemed speakers for today and so many of interactive esteemed delegates for today's session. I would like to thank you, sir, Dr. Kanikar, sir, for steering our discussion in the right ways with very apt questions and the discussions, and making sure that the session is also running smoothly. We got a lot more than what we had expected from the session today. Thank you everyone for that. And last but not the least, I thank Dr. Pallavi Dharmadhikari ma'am for such a beautiful technical arrangement. And the session did go very smoothly because of her. And all the participants, the delegates, there have been questions, active questions and interactions in the chat group as well. So, which is great. I think people don't want to take photographs. Sir.
Doesn't matter, आपला घेऊन टाका.
Acha, I have that.
I have prepared a nice plate of chicken, so I want to eat it now. Sunday special.
I think many people are there already. And yes. And before, I think we have already finished. We are on that last step of our session today. So thank you for everyone who has already registered for our AdolesCon. And a sincere appeal to anyone who is yet to register that please right now go and register to the to our national conference AdolesCon 2024, which is happening from 27th to 29th of September in our own wine capital of India. We want you to come here, enjoy the AdolesCon as well as enjoy Nashik. So a very, very, very sincere appeal to everyone to register for the conference as well. I think, sir, we can end the session today if everyone is okay.
Yeah. Thank you so much, everybody.
Thank you.
All the three speakers were excellent. Thank you so much. Have a nice
Thank
Sunday.
you.